Welcome back to Decode Healthcare with Harshal. If you hung out with us for part 7, you know we completely decoded the upper arm, tackling the humerus and the elbow. Well, today we're traveling further down the arm. In this explainer, we're diving deep into part 8, the forearm and wrist. Specifically, we'll be locking in on the CPT codes from 25,000 all the way through 25,999. Now, I know the 2500 series can look like a totally intimidating wall of medical jargon at first glance, but honestly, we're going to completely demystify these complex procedural codes today. And how are we doing that? By connecting them directly to the foundational, easy-to-understand anatomy of the arm. Because once you can actually picture the physical structures right beneath the skin, I promise you, the CPT guidelines naturally just click right into place. So here is our roadmap for today's explainer. First, understanding forearm anatomy. Second, repair and reconstruction. Third, distal radius fractures. Fourth, arthrodesis or wrist fusion. And finally, outro and next steps. Let's get to it. Section 1. Understanding forearm anatomy. Okay, let's establish our foundation. The forearm is built on just two bones right below the elbow, the radius and the ulna. And we are going to keep this incredibly simple. The radius is always on the thumb side of your arm. Just think of giving a thumbs up to remember that the radius is rad. The ulna, on the other hand, is the bone on the pinky side. Whether a surgeon is operating on the thumb side or the pinky side dictates entirely different CPT codes, so you always want to ground yourself in these two bones first. But it gets a bit more complex when we add the next layer. Imagine an intricate network of fibrous cords stretching down across the wrist and right into the hand. These are your tendons. Think of them as biological pulley cables. They operate all the movements of your wrist and fingers, but they're actually controlled by muscles housed higher up in your forearm. To code this section correctly, you absolutely must know what these specific cables do. Flexor tendons are the cables that allow you to bend your wrist and curl your fingers inward to make a fist. Extensor tendons are the exact opposite. They allow you to straighten your wrist and extend your fingers totally flat. So flex to bend, extend to straighten. If a surgical report mentions repairing a flexor, you know exactly which side of the wrist they're working on. So how does this apply to the CPT book? Well, the very first codes in this section, 25,000 to 25,2040, cover your basic incisions and excisions. These are minor but highly effective actions. For instance, a surgeon might perform a decompression fasciotomy to relieve crushing pressure inside a tight muscle compartment. Or they might simply go in to excise, which just means surgically remove, a benign cyst from the wrist bones. These are basically your foundational entry-level wrist procedures. Moving on to Section 2, Repair and Reconstruction. All right, here's your anchor in the actual CPT rulebook. Codes 25260 through 25295 govern tendon repairs. When a surgeon painstakingly sutures a completely severed flexor tendon in the wrist back together, using specialized threading to reattach those vital cables, these are the exact codes you use. You'll notice they specifically differentiate between primary, secondary, flexor, and extensor repairs. Now listen up, because here's the golden rule, the absolute critical CPT guideline you must memorize for tendon repairs. Step 1. Identify if the tendon is a flexor or an extensor. Step 2, and this is huge, you must code based on each individual tendon repaired. So if a surgeon fixes 3 flexor tendons in the wrist, you are reporting that repair code 3 separate times. And finally, step 3, carefully read that operative report to see if a tissue graft was utilized to bridge a gap in the tendon. If a graft was used, boom, that bumps you up to an entirely different, much more complex code. Section 3, Distal Radius Fractures. Okay, we're looking at codes 25500 through 25635. This section contains the dense fracture rules we're simplifying today. The distal radius is the end of the thumb side bone nearest to your wrist. And let me tell you, this fracture almost always happens the exact same way. Someone trips, they fall forward, they instinctively throw their hand out to catch themselves, and snap. The impact just shatters that distal radius. When treating this, surgeons generally have to choose between closed and open treatment. Closed treatment means the site is not surgically opened. The doctor simply manipulates the bone back into place from the outside and casts it. But open treatment, that's a heavy intervention. Picture a clear, bright X-ray showing a broken distal radius that's been repaired openly. The surgeon actually opens up the wrist and screws a titanium locking plate directly onto the radius bone. It is essentially bolting a highly engineered metal splint straight into the skeleton to hold all those shattered pieces perfectly still while they heal.
Section 4. Arthrodesis or wrist fusion.
The big vocabulary word we need to master here is arthrodesis. For beginners, arthrodesis simply means the surgical immobilization or the permanent locking together of a joint. The surgeon intentionally goes in, removes the cartilage, and fuses the bones together so that joint can literally never bend again. When we look at the CPT book, you'll see how it classifies this permanence. Codes 25800 to 25830 cover wrist arthrodesis, and these codes escalate based on the complexity of the fusion. Specifically, they look at whether the surgeon had to harvest sliding grafts from the local bone or if they had to take a larger autograft from somewhere else, like the iliac crest in the hip, to pack between the wrist bones and force them to fuse solid. Now, you might be wondering, why on earth would a surgeon ever intentionally lock a patient's wrist permanently? Well, the main clinical application here is severe bone-on-bone arthritis. The pain of those bones grinding together becomes so agonizing that the patient literally can't use their hand anyway. So the surgeon goes in, usually places a large metal plate spanning all the way from the radius bone down into the carpal bones of the hand and fuses it. It permanently stops all that painful movement. Basically, they're trading flexibility for a completely pain-free, stable wrist.
Section 5. Outro and next steps. All right, if you found this breakdown valuable today, definitely make sure to subscribe to Decode Healthcare with Harshal so you never miss an explainer. Because next up is Part 9. And we are dropping down even further into the 26,000 series. We're going to explore the hands and fingers, delving into the absolute intricate microsurgery of the digits.
So I'll leave you with this final thought as you study your CPT books this week. If repairing a thick cable in the wrist requires such precise coding, how much more exact do you think the rules become when we're reconstructing the microscopic pulleys inside your pinky finger? Keep studying, stay focused, and I'll catch you in the next explainer.